Good afternoon, everybody, and welcome to today's CME lecture. I am Dr. Jemelyn Garcia, and I will be your moderator for this afternoon. This CME event is brought to us by Philcare Pharma. We all recognize that multidrug-resistant organisms are still on the rise. And to date, we still have limited treatment options for these kinds of infections. Apart from carbapenems, can we still use our existing antibiotics for the treatment of MDROs, specifically gram-negative resistant organisms? To help us answer this question, let me introduce our speaker for today. Dr. Joseph Adrian Buensalido is the chair of the Infection Prevention and Control Committee of the Asian Hospital and Medical Center. He is the Deputy Training Officer of the Division of Infectious Diseases, Department of Medicine of the UPPGH. He is also the Deputy Head of the Center for Tropical and Travel Medicine of Makati Medical Center. And lastly, he is also a training corps member of the Department of Internal Medicine of both UPPGH and the Asian Hospital and Medical Center. To help us understand the role of tigecycline in the treatment of MDROs, colleagues, please welcome Dr. Joseph Adrian Buensalido.
Thank you so much for that kind introduction, Dr. Jemelyn Garcia. So good day again to one and all. I'll be talking about Tigecycline Therapy, a potent carbapenem-sparing weapon against MDROs, or multi-drug-resistant organisms, particularly CRE, or carbapenem-resistant Enterobacteriaceae, and A. baumannii, or Acinetobacter baumannii. As a background, all of us know that there is increasing carbapenem resistance, particularly from the CRE that we just mentioned. Also, we do know that delays of appropriate empiric antimicrobial therapy and inadequate therapy increase morbidity and mortality, as well as prolongs hospitalization. And when we say empiric, inappropriate or inadequate therapy, usually we mean that the choice that we make of antibacterial regimen does not actively cover the pathogen down the line, okay? And treatment options are also often limited. Here we show some of those options: carbapenems, polymyxins, including polymyxin E or colistin, tigecycline, fosfomycin, and other combination therapies. However, recently, the Infectious Diseases Society of America came out with guidance for the treatment of gram-negative bacilli or gram-negative infections, okay? So they actually have recommendations for CRE, separated into uncomplicated cystitis, pyelonephritis, and complicated urinary tract infections, and of course, non-urinary tract infections. Among those in the non-UTI group, carbapenemase-producing Enterobacteriaceae are included, including KPCs, or Klebsiella pneumoniae carbapenemase positive bacteria, wherein they recommend ceftazidime avibactam, meropenem vaborbactam, imipenem cilastatin relebactam. And for NDMs, or the New Delhi beta-lactamases or other metallo-beta-lactamases, they also recommend ceftazidime avibactam plus aztreonam, or cefedericol, And for the OXA48s, they recommend ceftazidime avibactam. However, as we know, not all of these are available in our country, and of course, the costs are high, for these new drug options. Also, the IDSA guideline now tell us to try and avoid polymyxins. And they also say that combination therapy not be routinely done anymore. Whereas tigecycline and all of that, in the new guidance, tigecycline actually is in the intra-abdominal infection area. For uncomplicated, they recommend the standard dose, which we shall see later. And for complicated intra-abdominal infections, they do recommend a high dose, and we shall also look what high dose means. The good thing about tigecycline is that it is active against KPC, metallo-beta-lactamases, and OXA48. So that's one of the advantages of tigecycline. So this slide set shows that there's now a generic tigecycline in our country, which according to them has cost savings of around 30% compared to the innovator. So tetracycline is the first glycyl cycline in the tetracycline class of antibacterials. It has a unique chemical structure. As you can see, it in the square is the unique side chain, which is actually responsible for the expanded broad spectrum activity of tigecycline. It also allows avoidance of tetracycline class resistance mechanisms. Just a snapshot on the pharmacokinetics and dynamics of tigecycline. In this slide, I think the most important will be that tigecycline is a concentration-dependent killer, all right? Meaning a higher dose is actually the more important one than time above the MIC, which is why AUC over MIC, or area under the curve above the minimum inhibitory concentration, is the most important parameter. And actually later on we shall see that the first 24 hours of AUC above the MIC is very important in tigecycline. And as for metabolism, mainly tige is biliary excreted, although 33% is metabolized or excreted through the renal route. So for this slide, we're going to see that tigecycline has an attractive tissue serum distribution profile, and it really displays a good penetration in pulmonary tissues. Now let's examine the table. So for gallbladder, after a patient received, or patients received 100 milligram single dose of tigecycline, they found that the tissue concentration in the gallbladder was 38 times the serum. Okay, pretty good. In the colon, there was a 2 times increase, compared to the serum. If you look at the skin blister fluid, though, it was 26% lower than the serum, despite 100 milligrams of loading dose of tigecycline and 50 milligrams IV every 12 hours. But the real advantage is in the pulmonary tissues. Look at the alveolar cells. After the loading dose and 50 milligrams Q12, they found a 78-fold increase in the alveolar cells of tigecycline when compared to the serum. In epithelial lining fluid, 32% greater than the serum. And in the lungs, after a single dose of 100 milligrams of IV tigecycline, an 8-fold increase compared to the serum. Just note that in the synovial fluid and in bone, the penetration is not as good. Now we go to the mechanism of action. As you can see here, tigecycline inhibits protein translation in bacteria through ribosomal binding, particularly in the 30S ribosomal subunit. In fact, it has better binding affinity when compared to the older tetracycline and minocycline. We mentioned this earlier, that it is able to overcome the 2 common mechanisms of tetracycline class resistance, and that's ribosomal protection and efflux from the cell. Efflux is the ability of some bacteria to spit out the antibiotic when they are exposed to it. And tigecycline is known to be bacteriostatic. However, it can become bactericidal in some isolates of Streptococcus pneumoniae and Legionella pneumophila. Now this slide shows the expanded broad spectrum in vitro activity of tigecycline. And you have there, on the left column, the many different classes of antibiotics. So beta-lactam and beta-lactamase inhibitor, third generation cephalosporins, glycopeptides, carbapenems, and quinolones. Among all the classes, you see that tigecycline cuts across and has activity against gram-negatives, gram-positives, resistant gram-negatives, resistant gram-positives, including MRSA, and even anaerobes. The others, there are a lot of white areas, meaning that many of the different classes lack activity in certain classes of, or certain types of bacteria. The closest would be the carbapenems, but carbapenems don't have activity versus a resistant gram-positive, which tigecycline has. On the other hand, tigecycline doesn't have Pseudomonas activity. So we mentioned this, that tigecycline is not affected by common antibiotic resistance mechanisms. When we say common antibiotic resistant mechanisms, we mean beta-lactamases, including ESBLs and carbapenemases. Why? Because tigecycline is not a beta-lactam. And that holds true with the penicillin binding protein alterations, which actually is a resistance mechanism against beta-lactams. Again, tige is not a beta-lactam. Also, DNA gyrase mutations do not affect tigecycline, since tigecycline is not in the fluoroquinolone category. Now, this slide shows the 2018 Sentry surveillance program and shows the activity or the susceptibility of the different bacteria to tigecycline. We'll focus on the Enterobacteriaceae, and the numbers on the right column shows the susceptibility, percent susceptibility of the bacteria to tigecycline based on FDA and UCAST breakpoints. Therefore, you have two numbers. But for Enterobacteriaceae, very good, 98 or 94%, depending on the whether FDA or UCAST. For CRE, still pretty good, 93% or 83%. For multi-drug resistance, or MDR, 94 and 86%, still adequate. For XDR, I would say still pretty good, given the extensive drug resistance, 89 and 78%. However, for Acinetobacter baumannii, 76 or 40%. So, but that's for monotherapy. Okay. Now, I also looked at the ARSP 2019, which just also came out. But for cholera in the ARSP, the tetracycline resistance was just less than 1%. For gonorrhea, tetracycline resistance was 58%, so pretty high, But for Staph aureus, okay, tigecycline has activity for staph. There was just 7% resistance for tetracyclines in general. For skin and soft tissue infections, Staph aureus infections, just 5%. For bloodstream Staph aureus infections, just 7%, okay, resistance to tetracyclines. So pretty good, still pretty good. For MRSA, just 6% resistance. However, for E. faecalis, we didn't find any except for the urine, but resistance was high for both faecalis and faecium. I didn't find any E. coli data in our ARSP, but for Acinetobacter baumannii, minocycline was the one mentioned, only 3% resistance, and even for bloodstream infections caused by ABAL, almost 2% resistance. So all in all, in our country, just based on the ARSP, tigecycline, which is in the tetracycline class, has still very low resistance in most. Now we go to common treatment emergent adverse events. If we see here, tigecycline when compared to imipenem does have a little bit more nausea and vomiting, but less headache compared to imipenem, less phlebitis, and more infections, secondary infections, and a bit more bilirubinemia and jaundice. So, but in general, GI side effects. This is what we mentioned earlier. What is the standard dosing of tigecycline? The loading dose is 100 milligrams, followed by a maintenance dosing of 50 milligrams IV every 12 hours. Infusion rate is recommended to last 30 to 60 minutes, and it's not recommended to co-infuse it with amphotericin B, voriconazole, methylprednisolone, and chloramphenicol, which we don't use that much anymore anyway. One important feature is that we do not need to adjust tigecycline in patients with renal failure and mild to moderate liver dysfunction. However, if the hepatic dysfunction is severe, like Child-Pugh C, then it's recommended to reduce the maintenance dose to 25 milligrams IV every 12 hours. As in tetracyclines, other tetracyclines, we recommend it above 18-year-old patients. Now we look at the many studies on tigecycline. This first study that we will look at is by Bassetti, and he looked at the prescription behaviors for tigecycline in real-life clinical practice, and he looked at 5 European observational studies of 1,700 plus patients, and majority were in the ICUs. 80% already received previous antibiotic treatment, and 90% had one or more comorbid conditions. Pretty much the population that we also subject to or give tigecycline to. Apache is pretty high, 17. I think that's the mean, and the populations involved were both skin and soft tissue infection patients or intra-abdominal infection. Now, this study shows that in intra-abdominal infections, most who were given tigecycline were severely ill and high comorbid rates. Example, 76% of these intra-abdominal infection patients already had prior antibacterials. A majority had higher, above 15 Apache score, or SOFA score of more than or equal to 7. This next study by Montravers had the same, similar findings, but this time in skin and soft tissue infections. 70+% had prior antibacterials already. However, since it's a skin and soft tissue infection group, the Apache scores were, of the lower type, although 50% versus 44%, and SOFA score 59% for the less than 7, and 40% for the more than or equal to 7 SOFA scores. So that's expected since it's an SSTI. Now, looking at the Girao study again, the mortality, but this is combined mortality for intra-abdominal infections was 18%, and then for SSTIs 9%. Just to give a view of how many died in those European observational studies. So, what were the reasons that the physicians then ordered tigecycline for those mostly ICU patients? Failure of previous therapy. So we know this. This is also how we use it. All right. The need for broad spectrum antibiotic coverage, 41%, and we already saw the expanded coverage of tigecycline. The suspicion of resistant pathogen, 39%. We also saw earlier, or we mentioned earlier, that tigecycline has activity against the multiple resistant bacteria, KPC, OXA, and NDM or metallobeta-lactamases. However, in this collection of studies, they found that tigecycline was used as monotherapy in 50%, which we hardly do these days, right? So therefore, tigecycline in this study, was able to show that tigecycline is actually being used for critically ill patients. And despite that, look at the clinical response rates. Although this is an observational study, clinical response rates were nearing 80% as monotherapy in half. Now, since in the past 10 years, I think, the standard dosing of tigecycline has been put into question, whether it was truly effective in MDRO infections, particularly in the critically ill, because there have been studies that showed that the standard doses of tigecycline have been shown to have higher therapy failure and high mortality. And this may actually be the reason why, in critically ill, many of them are septic, and that increases cardiac output and increases clearance. And sepsis also causes leaky capillaries, altered protein binding, and this causes an increase in the volume of distribution of these patients, causing low plasma concentrations of the antibiotic or any of the other medications. So tigecycline, because of high volume of distribution in healthy and normal patients, because of sepsis, may not be as good if you use the standard doses. And that is why high-dose tigecycline was really explored. And later on, we will look at some of the studies that show that high-dose tigecycline may really overcome the major drawback of tigecycline in terms of pharmacokinetics. Especially because, as we mentioned earlier, tigecycline is actually a concentration-dependent antibacterial. So what is high-dose tigecycline? You load with either 200 to 400 milligrams, okay, and you maintain a dose of 100 to 200 milligrams every 24 hours. So you can divide that either 50 Q12 as usual or 100 Q12. Duration, of course, will depend on the severity of infection. Now, we mentioned that in healthy people, tigecycline really has good penetration to the lungs. However, this study by Burkhardt, although this is not a trial, it just looked at the concentration of tigecycline in plasma, epithelial lining fluid, and alveolar cells, using standard dose of tige. If you look at the graph above, the alveolar cells do have good levels. However, the epithelial lining fluid and serum are actually lower, and this is usually seen in the critically ill patients, because of the pathophysiology that we mentioned a couple of slides back. Now, this table also shows that standard dosing of tigecycline may be suboptimal for MICs above 1 or for higher MICs in general. If you look at the first row, the AUC in the first 24 hours above the MIC, and that target of more than 6.96, which is the target for intra-abdominal infections. If the MICs reach 2, the PTA, or the probability of attaining the target, becomes 34%. Therefore, MIC matters, so we also have to look at that. Now, the second row that shows the target of above 17.9, that is the target for SSIs, or complicated skin and skin structure infections. Look that if the MIC reaches 1, okay, the probability of target attainment becomes red, so MICs really matter. And a suboptimal dose of tigecycline may really accelerate development of resistance and therapy failure. Now, this study by Ramirez, this one is a randomized control trial, okay, and it is on HAP and VAP patients, comparing tigecycline versus imipenem, but using higher dose of tigecycline. Okay, if you look at the red one, which is the high dose tigecycline, it's numerically more advantageous, in terms of clinical cure compared to a lower dose of tigecycline and imipenem. So the red bars are higher numerically compared to the other two regimens. So this just is one study that shows that killing power, in quotation marks, is significantly improved using high dose of tigecycline. So another study by De Pascal, also on ICU patients, using high dose of tigecycline combination therapy, and they looked at clinical cure and bacterial eradication. Okay, they looked at 100 ICU patients, 63 VAP patients, and shown here are the susceptibility breakpoints and resistance breakpoints. Okay, what did they find? They found that high-dose tigecycline increases the odds of clinical cure by around 6.25 times, okay, with a p-value of 0.009. That's very significant, all right? And they also found that a higher SOFA score at the start, and inadequate initial antibiotic regimen reduces the chances of clinical cure. So really, it's very important to use high-dose tigecycline if that's what you're going to use, and you have to have you have to choose a correct regimen, something that will most likely hit the organisms. Now, among the studies that I've so far presented, Gong study is one of the more comprehensive one. It is a meta-analysis of 3 RCTs that are high quality, and then 14 plus 14 non-randomized trials. I took the liberty of checking its directness to our question, high dose versus low dose. Yes, the population is, of course, those who have bacterial infections, and they looked at high dose versus low dose tigecycline. And the outcomes they looked at were mortality, clinical response, microbiologic eradication, and of course, adverse drug reactions are very important. I looked at the validity of this study, and the inclusion criteria were good. The search that they did was thorough. The included studies looked valid to me, and it looked like the meta-analysis could be reproducible. So let's just look at the results. Here they summarize it. The all-cause mortality, the RR risk reduction is 0.67. So that means a 33% statistically significant reduction in mortality when you use high-dose tigecycline compared to low-dose or standard dose tigecycline. It's pretty good, And I actually looked at the subgroups, In the non-Chinese studies, there was just a trend. However, in the 5 Chinese studies, they had an almost 50% reduction in mortality, and similar 40% reductions in mortality in VAP, nosocomial pneumonia, and in intra-abdominal infections using high dose. The reduction in mortality actually reached more than 85%. However, in bloodstream infections, they did not see, which as we usually use, usually use bactericidal, and we know tigecycline is bacteriostatic, so not our first choice for bloodstream infections. However, for pneumonias and intra-abdominal infections, the evidence from the study looks good. And the other good thing is that the heterogeneity is actually low to 0. Okay, almost no heterogeneity at all. And look at the second box below. That's clinical response rates. There is actually a 46% increase in clinical response when you use high-dose tigecycline. And I also looked at the subgroups. Again, a trend in the non-Chinese studies, but that's just 2. I think the data is driven by the Chinese studies. 10 Chinese studies showing a 49% or 46% increase clinical response if you use high-dose tigecycline. Similar to VAP and nosocomial pneumonia, with also low to 0 heterogeneity. So we go to the next slide. This is on the slide on adverse events. Look at the RR, it's 1.0, and the confidence interval is 0.8 to 1.26. really just showing that there is no difference in terms of adverse effects or safety when you use high dose over standard dose tigecycline. Pretty good. Meaning the higher dose didn't really cause more adverse effects than the standard dose. So this slide shows a couple of international guidelines. Of course, tigecycline is there, scattered throughout the community-acquired nosocomial. However, in our practice, usually we of course give it for nosocomial, right? Of course, as you saw in the IDSA guidelines, you can still give it for uncomplicated intra-abdominal infections. So tigecycline actually is a potent choice against a wide range of MDROs. We mentioned CRE, we mentioned KPCs, OXA, we mentioned NDMs and the other metallo-beta-lactamases. Tigecycline has activity against all those. No? It has broad spectrum activity. We looked at that broad spectrum, no? That's similar to carbapenems, except that tigecycline has MRSA coverage. Carbapenems don't have. However, Tige does not have Pseudomonas coverage. We also looked at the lack of cross-resistance with other classes of antibiotics. No? There's limited drug-drug interaction since it is not metabolized by CYP450 pathway. And we mentioned that there requires no dose adjustment in renally compromised patients. So one of the therapeutic options of tigecycline are as follows. We mentioned no need to dose adjust for renal impairment, mild to moderate hepatic impairment in the elderly. And we don't have to worry about penicillin allergies since it's not a beta-lactam. We know that carbapenem may cross-react with penicillins or beta-lactams, but the range is wide, 6 to 40% possibility of cross-reaction of carbapenems to those who have penicillin allergy. Now, people on multiple medications, good to know that there are limited drug-drug interactions and no significant interaction with warfarin. So we tackled a lot, no? And these are the take-home messages in our increasing MDRO environment, especially in the hospitals, with limited available therapeutic options, and some are, expensive, some are not yet available in the Philippines. Tigecycline is actually a real valuable option, empirically or in combination. Tigecycline is frequently administered to a subset of high-risk and complicated patients with sepsis, septic shock, a lot of comorbidities, a second-line therapy. ID specialists and intensivists use tigecycline in both approved and off-label indications. Considering increasing incidence of CRE, tigecycline has a potential role as a carbapenem-sparing drug. No? However, there have been studies that you can also combine it with carbapenems. No? And then standard dose tigecycline appears to be underdosed if your enemy is the MDRO, a multi-drug resistant infection. No? And optimal dose would be using a high-dose tigecycline so that you reach the desired and targeted AUC over MIC in the first 24 hours. This will be more effective against most gram-negative pathogens, including the resistant ones. And compared to other alternatives, tigecycline has certain inherent advantages for critically ill patients, including no need for dose adjustment for most indications. So thank you so much for your attention. Okay, so that's the last slide. Thank you so much for your attention, and I'm open to any of the questions that you may have submitted in the chat box to Dr. Jemelyn Garcia.
Okay, thank you, Dr. Buensalido, for walking us through the role of tigecycline in clinical practice. And it's good to know that we can still use our currently available antibiotics as part of our armamentarium for treatment of gram-negative infections, even for MDROs. So let me just check the questions here in the Q&A box. So a question from an anonymous attendee: is it okay to use tigecycline as monotherapy for CRE?
Yeah. Can you hear me?
Yes.
Yeah. Yeah. So I would not use it monotherapy in most cases, no, because usually when we start to use tigecycline, no, we are at the end of the line, so to speak. Um, and then usually especially in the hospitals, we don't usually see a susceptibility to tigecycline that's automatic, right? Especially when the cultures come out. So in general, I use it in combination most of the time with other antibacterials. No? It's hard, especially if there's you don't have a culture that shows it's susceptible. Secondly, many of these patients are critically ill. Tigecycline is bacteriostatic, although outcomes, as we've shown, are good with even 50% monotherapy. But then, these patients are usually more ill than our community acquired patients. No? So it's my preference actually to give it in combination with another antibacterial. There is a meta-analysis, just to answer that question, a meta-analysis on gram-negative carbapenemase producing bacteria. No, I think it was in just this year, I think. No, but it's not focused solely on tigecycline. But the main finding is that in these carbapenem-resistant gram-negatives, monotherapy has actually increased mortality. So that is another piece of evidence. I think that's even higher in terms of grading compared to just clinical experience, no? or expert opinion. That one is a meta-analysis. So yeah, I would rather use it in combo.
Okay. So as a follow-up to that, so you said you use it in combination. So for which clinical indications do you usually use tigecycline, and with which other antibiotics do you combine it with?
Clinical indications, most common is after meropenem failure, no? Or if a patient already received meropenem, and then a patient incurs, no, or gets another infection, no. So in general, one of the options that I have is to at that point, no, instead of going to the more expensive options, I would restart meropenem and add tigecycline. The advantage of tigecycline in that circumstance would be it covers, no, Acinetobacter baumannii. It covers all the carbapenemases, no, and then it also covers for MRSA and even Enterococcus, no. So with that regimen, no, I increase the maximum coverage, but at the same time, I try to avoid the nephrotoxicity with other agents that I could use.
Yeah. So you said in most of our susceptibility tests, tigecycline is not commonly included. So that means we can actually use it as empiric therapy.
Correct. Many times it's what we use for empiric therapy. Like I said, in that circumstance wherein you already used a carbapenem, no? That's why my advice really is to, when we start our antibacterials, no, we risk assess our patients, meaning we assess for risk for resistance, no, as is present in the guidelines, no. So if possible, we can try to start off, especially in community-acquired infections, with non-pseudomonal agents, and then we can go up to maybe a third generation or fourth generation anti-pseudomonal cephalosporin. Then let's not automatically go to piptazo, because after piptazo, our next will be meropenem, and after meropenem, then we need to go to the last line drugs for drug-resistant infections.
Mm-hmm. All right. So you talk about something new here in the lecture, which is high dose tigecycline. So I'd like to ask if you've had any experience using high dose tigecycline.
Yes, I've had, but to tell you the truth, I've started using it fairly recently. In the past, I used to use just the standard dose a lot, no? But really, if you go back to the lecture earlier, Gong's study for me is pretty impressive, no? Pretty convincing. That if I'm going to use high dose, or if I'm going to use tigecycline, no, it's better to use it as high dose, no, because really the mortality benefit is there compared to low dose, and we know that the low dose tigecycline had was actually subject to a black box warning because of increased mortality. And when this study by Gong showed that high dose reduces the mortality, microbiologic eradication, increases microbiologic eradication, increases clinical cure without increasing adverse drug effects, no? Then it actually, if you think about it, counteracts the black box warning that was given a decade ago.
Yeah, so you actually also confirm based on your experience that the high dose does not really increase the incidence of adverse events.
Yes, yes. And my experience is just one, but if you, like we mentioned earlier, the evidence, no, of a meta-analysis, no, is actually higher than one expert's
Clinical
opinion.
experience. Yeah.
Yeah.
Well, there is a related question here for high dose tigecycline. Does it not increase the risk for liver injury? And if yes, how can it be minimized or prevented?
The good news, no, this is really a one important question, no, which was actually answered by the meta-analysis, no. The high dose does not increase the adverse effects, no. What are these adverse effects, no? Diarrhea, nausea, vomiting, liver and pancreatic toxicity, and even hematologic and allergies, no, all are not increased when you use high dose tigecycline, no? But at the same time, you get the benefits, the clinical benefits of a reduced mortality, an increased clinical cure, and increased microbiologic eradication.
Mhm. Okay, so maybe one last question regarding de-escalation. So when you start tigecycline for a critically ill patient and the patient has improved, do you actually de-escalate to oral antibiotic or just finish off with the IV?
So many times, well, depending on the clinical circumstance, but many times these patients are really clinically sick, no? So many times I would complete the whole course using tigecycline. However, if you are really forced to de-escalate, no, if for example there is really good clinical response and patient responds quickly, and then there's really a significant improvement, no, of course, minocycline may be the your step down go to.
Mhm. Being in the same class, right?
Being in the same class, and yeah,
Mhm.
minocycline almost has similar spectrum, except that it's oral. So, but we know for critically ill patients, our first, of course, for our best bet would be to use the IV dose, and we know, as shown in the studies, no, in the data, no, that the standard dose is not really as good, especially in septic patients, given the increase in volume distribution, the faster clearance, no, by the
Mhm.
drug, in these critically ill septic patients. So, yeah, many times I really just finish the whole course of the tigecycline.
Yeah, okay. So I guess we have addressed all the questions in the Q&A box. So we have discussed how we can use tigecycline as still part of our treatment regimen for difficult to treat resistant organisms, including ESBLs, MRSA, and Acinetobacter. So indeed, it is a very versatile drug because it has gram-positive, gram-negative coverage, and anaerobic coverage, no? And it could be part of our treatment even for multi-drug resistant organisms. But of course, being an AMS advocate, I cannot end this session without saying that we still need to apply the principles of antimicrobial stewardship in our clinical practice by giving the right drug at the right dose for the right indication and for the right duration. So with that, I think I will close this session on behalf of Philcare Pharma and Dr. Buensalido, our speaker. I would like to thank FPSMID for allowing us to conduct this CME activity during the annual convention. And Philcare assures FPSMID that they will be in continued partnership with PSMID for CME activities like this. So I would like to thank the audience for listening and for posting your questions in the Q&A box. So with that, I end the session and have a good afternoon, everybody.
Thanks, Jem.
Thank you.
Good afternoon, our dear doctors. On behalf of Philcare Pharma Incorporated, we would like to thank the Philippine Society for Microbiology and Infectious Disease for giving us this opportunity to participate in this 42nd annual convention. Of course, we would like to thank the organizing committee, along with its officer and staff of the Philippine Society for Microbiology and Infectious Disease for this very successful event. And definitely, we will not forget to thank our speaker, Dr. Joseph Adrian Buensalido, and our moderator, Dr. Jemelyn Garcia, for providing us a very informative discussion of tigecycline as a potent carbapenem-sparing weapon against MDRO infections, like our CRE and A. Baumani. So as always, we in Philcare Pharma, we promise to partner with the Philippine Society for Microbiology and Infectious Disease in providing quality healthcare needs and services to all the Filipino people. Once again, thank you and a pleasant day to all.